Hi everyone, my name is Med2Med. Today's session is going to be about infective endocarditis, which, like many other conditions we've talked about on this channel, needs to be recognised and treated very quickly. These notes are based on the following resources. I've been using the PDF from scotsnotes.co.uk, the Oxford Handbook of Clinical Medicine, and the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. So the main rule of thumb is, if a patient has a fever and a new murmur, you should suspect endocarditis until proven otherwise. So what is endocarditis? Well, it's an infection of the heart, usually the valves. We used to classify it in terms of subacute and acute. Subacute is usually caused by streptococci and progresses over weeks and months. Acute, however, is a fast-pacing illness, so less than 2 weeks typically, and the infection has a tendency to spread. Often this is caused by Staph aureus. We don't really use this classification system anymore because there's also chronic and fungal endocarditis. And the organism wasn't always directly related to the patient's prognosis. However, it is good to bear in mind. Some things put patients more at risk than others of developing infective endocarditis. These factors include prosthetic valves, valve diseases, congenital heart defects like a patent ductus arteriosus or a ventral septal defect, rheumatic fever, having dental work done, post-operative wounds, being an IV drug user, and being immunocompromised. I've got a list of the bacteria which can cause infective endocarditis. Of course, it can also be fungal, as we've mentioned, so that's things like Candida, Aspergillus, and Histoplasma. Fungal infections tend to occur in IV drug users, perhaps in immunocompromised patients or also those with prosthetic valves. It's worth noting that strep viridans is the most common and is subacute in presentation. Then, on the negative side, there are these typical 5 bacterias and a couple extra. Take a few seconds just to cast your eyes over these, and pause if necessary. So how do we recognise infective endocarditis? Well, symptoms can be split regarding how they manifest. That's signs of sepsis, signs of cardiac lesions, immune complex deposition effects, and embolic phenomena. We'll explore each of these categories separately. So, typical signs of sepsis. We've got fever, rigors, so these are really vigorous shakes, night sweats, malaise, weight loss, anemia, splenomegaly, and clubbing. Here we can see a really clear photo of finger clubbing. In terms of symptoms based around cardiac lesions, you may notice a new murmur or a change in a patient who already has an established murmur. Aortic root abscesses cause prolongation of the PR interval, which can result in complete AV block. Then lastly, left ventricular failure can actually occur and is a very common cause of death in these patients. Then there are signs of immune complex deposition. Vasculitis can occur in any vessel. You may notice microscopic hematuria, and with that, glomerulonephritis and acute kidney injury. If you want to go over GN or AKIs, I have a couple of lectures about these two conditions as well. Then, patients may also have Roth spots, splinter hemorrhages, and Osler's nodes. We've brought up a few signs here, so let's go over a few of them. Firstly, Roth spots are these boat-shaped retinal hemorrhages, and they have these really pale centres, which you can see on this image here. These are splinter hemorrhages, which are normally found under the fingernails or toenails, and are reddish-brown in colour. Then, where there is emboli, you may find abscesses on the brain, heart, lung, kidney, spleen, or in the gut. And lastly, Janeway lesions may occur. So here is a picture showing both Osler's nodes and Janeway lesions. Osler's nodes are tender pulp infarcts, whilst Janeway lesions are not tender, and are these erythematous, hemorrhagic, or pustular spots on the palms or soles of the feet. There are various tests which may uncover clues towards the diagnosis of infective endocarditis. Firstly, you do some blood cultures, which you repeat a few times. Then you carry out blood tests. You may find that the patient is normochromic, has normocytic anemia, neutrophilia, or raised erythrocyte sedimentation rate or C-reactive protein levels. Then, in urinalysis, you again may see signs of these immune complex depositions, like microcytic hematuria, which points towards glomerulonephritis or AKI. A chest X-ray could reveal cardiomegaly and pulmonary edema. An ECG could show heart block, which we mentioned, caused by an aortic root abscess. Echoes can show vegetations, mitral lesions, or again this aortic root abscess. And CT can show the emboli we've spoken about. There's a diagnostic criteria called the modified Duke criteria, which is required for a diagnosis of infective endocarditis. You can have 2 major, or 1 major and 3 minor, or all 5 minor criteria. For the major criteria, there has to be a positive blood culture that is in 2 separate cultures or several persistently positive cultures. Alternatively, this criteria is met with just 1 positive blood culture of Coxiella-Burnetti. Then you need endocardium involvement. This is the second part of the major criteria, and it's a positive echo that shows things like vegetation, abscesses, that sort of thing, or abnormal activity around a prosthetic valve, paravalvular lesions on a cardiac CT. Then, for minor criteria, the patient should have a predisposition, i.e. they meet the risk factors we spoke about. They should have a fever greater than 38. They may have vascular phenomena that we've mentioned, like the emboli or the Janeway lesions, that sort of thing. Immunological phenomena like glomerulonephritis, Osler's nodes as well. And lastly, a positive blood culture that doesn't quite reach the criteria, so that could be 1 positive culture of strep. Let's move on to treatment of infective endocarditis. Firstly, you should refer these patients to a cardiologist and to micro. Then, antibiotic options include different choices depending on whether there's a native or prosthetic valve in situ, as well as considering the type of bacteria and whether the patient has a penicillin allergy. You should consider surgery in patients who have heart failure, valvular obstruction, repeated emboli, any fungal endocarditis, persistent bacteria in the blood, a myocardial abscess, or an unstable infected prosthetic valve. In fact, 50% of patients require surgery to treat infective endocarditis, but it still has a 20% in-hospital mortality rate, and 15% of cases recur within 2 years. You should discuss a few things with your patients who may be at risk of infective endocarditis. Although antibiotic prophylaxis used to be given routinely for dental procedures, it is no longer recommended. However, you should encourage the patients to maintain good oral health and consult a doctor for any advice regarding any body piercings and tattoos. Okay, so that's it for infective endocarditis. Let's go over a summary. First, you should treat any fever and new murmur as endocarditis until proven otherwise. Symptoms of infective endocarditis are related to sepsis, cardiac effects, immune complex deposition, and embolic phenomena. The signs you might find on your patient include a cardiac murmur, Osler's nodes, Janeway lesions, splenomegaly, and clubbing. You should use the modified Duke criteria to diagnose infective endocarditis definitively. You should treat with your antibiotics according to your local guidelines. All fungal endocarditis cases need surgery. and you should encourage good patient awareness, including proper oral hygiene and understanding the risks associated with body modification. And that's it. Thank you for listening.